Hello, my name is Kumar Madassery. I'm an interventional radiologist from Rush University Medical Center in Chicago, Illinois. I also run the Advanced Vascular Interventional Radiology Fellowship and run the CLI program. It's a pleasure to have you here with me today. First and foremost, I want to thank Dr. Walker for putting this effort together in this crisis that we're dealing with. I think it's really great to see the effort on education and still being able to reach out even though we can't all be together. I think there's a lot more things we can do virtually in the meantime, and this is hopefully one of them. My hope today is to talk about pulmonary imaging and anatomy, which is relevant to interventions for pulmonary embolism primarily, which is kind of the main topic that we're talking about. So moving right ahead, I hope to talk about some of the anatomy as well as the approaches to getting the pulmonary angiographic images as well, which some of it is related to operator experience and preferences. So basic anatomy, as many are pretty comfortable with by now, I hope. The right lobe is separated into 3 lobes, the left lung is separated into 2 lobes. The arterial vasculature tends to follow the airway branching as well, as you can see on this image. You can see that there's a right and left main stem and then splits into each individual lobe, which is kind of similar to what we see on imaging for PE. As you can watch the vascular anatomy here, the blue is the pulmonary arteries. And once you get into the pulmonary outflow tract, you get into the right and left. There's an apical vasculature. There's bronchus intermedius, which goes to the right, middle, and lower lobes. And on the left, you see kind of the 2 main branches, including the lingula, which is technically the 3rd part. Now, when we look at pulmonary embolism workup, the imaging tends to be kind of the more straightforward part. Is when to decide to intervene is the more complex part, which other speakers will be talking about in this segment. When we think about how PEs used to be evaluated, one of the first things we used to always get is an X-ray, a chest radiograph, which some still get. However, the diagnostic value is getting less and less. There are some signs that are classic and everyone should kind of have in their memory banks. Some of those are the Westermarck sign, the Fleischner sign, the Hampton's hump, and this kind of engorged vasculature, which are all kind of secondary radiographic findings of PE. Now, sometimes imaging delays behind the actual clinical symptoms and vice versa. So this makes X-ray not the most useful when we're trying to decide, is this patient having an acute PE that's significant? Is this something that we need to act on? So this modality is not something we use day to day to determine if we're going to treat a patient. Most every patient nowadays will get a CT scan. BQ scan, ventilation perfusion scan, done in the nuclear medicine department at most institutions. It's a little bit of the bane of the existence of some radiologists because we don't like reading these personally because we have other modalities. However, we do have a small subset of patients that have a difficult time getting a CT scan, whether it be holding still, whether it be IV access, whether it be contrast issues, kidney failure. So there is some value to this type of imaging, albeit it takes longer. The patient has to be able to remain still, and there's a lot of artifacts that can happen. And also there's a lot of subjectivity to when the operator decides to read out the study and say how significant they think the mismatch is. And what we're looking at is the ventilation preserved in an area that the perfusion is not, which means that there's a high likelihood of PE, and it goes into these categories. Again, a lot of clinical information has to go into this more than just the VQ scan, but it is another modality that many people should be aware of and that it is available, assuming the patient can tolerate it. Moving ahead to what we kind of do most commonly, the CT angiogram, or called CTPE. This is basically your standard approach in most places around the world to evaluate pulmonary embolism. It kind of came to fruition around 92. Some of the limitations we have to think about are patient's body habitus, which creates a lot of attenuation of the imaging on the CT scanner. So therefore, your arteries may not look as enhanced with contrast, and you may kind of pick up these little findings that make you question if it's PE or not. One of the things we look at is Hounsfield units to know if it's a good study. If in the pulmonary artery, the main pulmonary artery, we see about 250, 220, 250, we feel that's an adequate study. Breathing motion, patient motion, makes it really difficult to see the segmental and subsegmental pulmonary arteries. It still tends to be decent for any major saddle PEs or other issues like that, but these little motion artifacts can cause quite a bit of dilemma if you're trying to look at the smaller secondary tertiary branching of the pulmonary vessels. However, the scanners are getting faster and faster, so we're getting a little bit better with that with the technology helping us get over some of those limitations. This is a nice pictorial review from Lightman and McDermott. Shows kind of the X-ray findings, which we reviewed already. Now, in the middle image and also on the right image, you see the coronal mediastinal view and a lung view. What you're seeing where the arrow is pointing to is that there's a filling defect of the contrast in that kind of a diagonal segment of the pulmonary artery, and that's consistent with a pulmonary embolus. One thing many imagers have to determine is this acute, or could it be some element of chronic, or could it be acute on chronic? There's a little bit of experience and just understanding how it looks to that. On this one, you can see that the clot is kind of mostly in the central part of the vessel. There may be some contrast flowing around it. Those are sometimes signs of an acute pulmonary embolus. And also the clinical symptoms override most of this anyway. So you're trying to put all these pieces together to get to your final decision on where the patient is at. On this slide from the same paper, you see kind of 4 images showing different ways that the clot can look on different projections. And on the far left, you see the central kind of longitudinal linear filling defect. In the second image, you see kind of this, what they call a polo mint sign. The clot's in the middle and contrast around it. Usually acute clot tends to either jam the vessel completely or it'll be in the center of the vessel. That kind of gives you an idea that that's acute. And some pictures also on the third and fourth image. Now, chronic PE, how that looks for a lot of times, you'll see kind of peripheral eccentric clot circumferentially surrounding the vessel. So if you see filling defects, it's not in the central, there's contrast going through. However, you see just kind of circumferential thrombus appearing material, that's usually chronic. That can also become calcified. That gives you another clue. But on top of that, you may have acute clot because a patient can have multiple episodes since a lot of this travels from the lower extremities and so on. So this kind of just shows you how you pick out acute versus maybe chronic. But again, the clinical picture of the patient comes in with tachycardia, short of breath, and some of the other classic findings, it kind of gives you a better clue than anything else. Some of the things we talked about is, there's motion artifact, but there can also be streak artifact if the patient has metal hardware from arthroplasties, from bullets, from embolizations, from sternotomies. So many different things nowadays are being done that can cause artifacts. So those are some of the limitations. As mentioned before, faster and faster scanners, taking just a second or few to do the whole chest, have really helped us out significantly. Another thing that angiogram has really helped us with is by giving us an idea of how significant is the PE burden on the heart. And what we've been able to find now is by evaluating the RV to LV ratio, which is done almost on every scan now by most places, it gives you an idea of how the heart function is. And it's been well validated, confirmed with echocardiogram, that if you have a right ventricular to left ventricular ratio greater than 0.9, that's abnormal and the heart's at risk. As you can see on this picture, you can see how the right ventricle is larger than the left. And you can see the septum, which is in the middle, is kind of straightened. That's not how it normally is, as usually it bows into the right ventricle. So these are kind of some of the additional features of CT angiogram that's helped us kind of understand how significant is the clot burden to the patient's hemodynamic status. Echocardiogram is still a great tool. It's a lot easier to overcome some of the caveats of the patient that we refer to as CT, and it provides a great deal of information. Some people can have cardiomyopathy. They can have already existing cardiac dysfunction, which makes the RV-LV ratio maybe not as consistent. But the echocardiogram gives us real-time information as to how the heart is functioning, what kind of wall motion abnormalities are there, and some of the signs, as you can see here. What we look for is the right ventricular dilatation, the dysfunction, the septal motion. McConnell's sign is something that's referred to quite a bit, basically where there's sparing of the right ventricular apex while there's abnormalities in the rest of it, the right ventricle. And the other thing that it really helps us with, that CT can sometimes help with as well, is clot in transit, where you have thrombus sitting in the right atrium that may become a catastrophe for the patient. Whenever we see clot in transit, we immediately make sure we have our CT surgical colleagues on board for possible surgical embolectomy, as these can be very dangerous to the patient. Moving on now, once we decide that patient is appropriate for imaging from an interventional standpoint, or the other modalities have not been helpful and you still need to confirm it this way, we go on to pulmonary angiography. Based on operator preference, this can be done through the neck, usually the right internal jugular, or from the groin. It really depends on the experience and the preference, and sometimes what's going on with the patient. Some patients may have a difficulty with the groins. Some patients may have cervical collars and all these other issues making it difficult to go from the neck. Regardless of which way you go, the goal is to get into the pulmonary outflow tract. How we do that is from the neck, it's actually usually pretty straightforward to go with a reverse curve. Usually Cobra catheter gets you right into the pulmonary outflow. From the groin, there's a lot of different options for people. There used to be the Mont 1, which is a great catheter. It's basically an angled pigtail type catheter. A pigtail itself can be used, and that's assisted by using a bent back end of a regular guide wire just inside the pigtail to help angle it to get into the outflow. There's also the APC and the Grolman. Sometimes I prefer to use an H1 right at the cable junction, just aim it right into the pulmonary outflow. It tends to work. One thing to be considerate of now that we're doing more and more large bore mechanical thrombectomy devices is that it's ideal to use a pigtail or a catheter with a pigtail to get into the pulmonary outflow. There is a risk if you don't use one of these type of catheters that you could intertwine within the chordae, the musculature of the valves, and cause a potential rupture with these 20 French and so on devices that you're shoving into the pulmonary arteries. So in these situations, it's very highly recommended to use a pigtail type of catheter to get across. One little thing to think about, it is possible when you're trying to get into the main pulmonary artery to think you're in the main pulmonary artery, as if you look at the picture on this right from an angiogram of one of my patients in the past. And in fact, the catheter went right through a patent foramen ovale, a PFO. This can happen especially in patients with heart failure, PEs and all that, because that right ventricular pressure gets so high, the right system gets so high that it opens up the PFO and you might not realize you're in there. So before you do anything else, it's always good to do a puff of contrast, especially when you're not so sure that the location of your catheter doesn't look appropriate. As you can see on the cartoon, the PFO is kind of where you're trying to go into the, if you can see the arrow from the right atrium through the ventricle through here, instead it goes right through here, and you think you may have gotten to the right place when in fact you have not. So it's very important that you always make sure, and it's important to catch it before you make a bigger sheath go through there or any other devices. Now, once you get into the main pulmonary artery with your catheter, preferably a pigtail catheter, it's important to always check your pulmonary artery pressures first. You typically don't want to power inject a patient with really high pulmonary artery pressures. That can cause some deleterious effects. Everybody has their own numbers. Usually I say 50 millimeters of mercury or less, I'm usually okay. Some people may have a lower threshold, but also you need to take into consideration the patient's cardiopulmonary status. That may have some effects to it. If it is severely elevated, then it's better to do hand contrast injections, which don't get you sometimes as great as pictures, but it can get you all the information that you need to get. If you are doing power injection, I tend to use 20 for 40 or 25 for 50, depending on the patient's habitus and everything else. It really helps to have the patient holding their breath, which is difficult for some of these patients who are in respiratory distress. One thing of note when you're doing pulmonary interventions for PE, it's best to try to not have anesthesia. Try to use as little sedation as possible. The more sedation they get, the lower their pulmonary reserve and their cardiopulmonary reserve. And you can have patients take a dive when they're laying supine on your table with heavy anesthesia, deep sedation. So if possible, try to use as little of no sedation as possible. It makes very, very difference in your outcomes. So getting your catheter up to the pulmonary artery, there's a pigtail technique. If you look at the top picture, that's basically you have a pigtail catheter and there's a bent back end of a guide wire in there, which is trying to help you deflect the catheter in different directions. And what you're trying to do is go from the right atrium through the right ventricle and try to make this path right here. So by spinning this catheter, bringing it back, and try to use the angle of the pigtail with the wire, you're able to kind of navigate into the main pulmonary artery. And then you go on and take your pictures. This is the path that you're trying to trach. You're trying to go through if you're coming from the groin, the inferior vena cava, right atrium, kind of drop into the ventricle and find this outflow tract. Optimum imaging when you get into the pulmonary artery is that you have to consider, if you look at these two pictures, one is in the AP, which is on the left, and the other one on the right is RAO, or right anterior oblique. Many of us prefer that. If you look at the left, there's an overlap of the right and main left pulmonary arteries. If you look on the right, it's actually opened up quite a bit. One thing to remember is that the right main pulmonary artery kind of is lower and drops posteriorly, so That's why having an obliquity really helps you see the whole branching pattern a lot better. As you can see in these pictures, if you could notice, there's decreased perfusion on the right lobe on the patient on the left, on the image on the left, from a clot that you can see in the distal branches. And here in the second image on the right, there's significant amount of saddle PE basically in the main right and left pulmonary arteries with decreased perfusion in the upper and lower lobes. So it's really important to understand the obliquities, which really help you. This is from an article as well, which shows some nice branchings of the right and left main pulmonary arteries. The point of this is to show that if you really want to get better detailed pictures of each side of the lung, it's important to know which projections really help you to do that. If you're trying to see the main right pulmonary artery, then you want to go ipsilateral. But if you want to see all the branchings of the upper, middle, and lower lobes, you want to go contralateral. And this applies to the left side as well. You do ipsilateral to see the main left pulmonary artery and its branching. And then when you want to see the distal branches, you go contralateral. And that's something really important if you're really doing detailed work, which we should all aim to if you're working on CTEPH patients and things like that. You really want to understand which anatomy opens, which obliquity opens up your anatomy as best suited for what you're trying to do. One thing about selecting right or left, naturally your cathetered wire will want to go to the left main pulmonary artery because that's pretty much a continuation of the outflow tract. Once you do all that and you're trying to get to the right, what I've found helps me quite a bit is bringing a Cobra catheter or even a Bernstein, but a Cobra tends to work better for me. You got to pull it down in the pulmonary outflow tract more than you think to get into that right main pulmonary artery, which is a little bit lower and posterior. That's just the way that works for me, but everybody has their own choices. These are two pictures, one on the top with a power injection. You can see that there's filling defects and perfusion problems on the right lung, a little bit on the left. The picture on the bottom is a second day when you bring the patient back, hand injection through a sheath, which is in the main pulmonary artery. So what this is showing is that you can actually get really good images with both power and hand. It just depends on how much you're injecting, the patient's tolerance, motion, and all those put together, but you can achieve very good images in both methods. So correlating CT and your pulmonary angiographic findings, it really depends on the patient's stability, what their cardiac function is, if they have good output, their ability to hold breath, and also your contrast and volume injection. This is an example of correlating too. This is a picture I had earlier in the slide set. It's a coronal image of a patient with clot in the right lower lobar arteries, and you can already see there's a pulmonary infarct. And on this patient, you can see on the actual angiogram on the right, there's pretty much like a knuckling or a cutoff sign of that right lower lobe. There's clot in the lower lobar as well, and there's relative lack of perfusion. So this correlates with exactly what we were seeing. And that patient ended up doing mechanical thrombectomy and actually got considerably improved perfusion. And that's it. And I thank you very much for paying attention. And I hope that everybody stays safe and we get to do this more often. Thank you very much.